الجلسة الجاية على الفاليو بيزد ان براكتس، بيترأسها الدكتور عساف، وهنبدأ. اتفضل يا دكتور عساف. قدم الدكتور مصطفى.
Okay. Okay, Dr. Mustafa, I didn't get your bio. Okay, but I think the title of the presentation will be the performance data analytics and clinical indicators and value-based care at Saudi German hospitals, German healthcare. And and this is Dr. Mustafa Galwash. And he is also the Chief Quality Officer for the Saudi German Hospital. And I wanted to tell you that I worked with the Saudi German hospitals. They have a great model, and I think they have done extremely well in Saudi Arabia. And I think they are not only in Saudi Arabia now, they have it in Egypt, they have it in UAE, so they are moving in the right direction. Very well. Take care. Thank you very much.
طيب السلام عليكم. بسم الله والحمد لله والصلاه والسلام على رسول الله. انا دكتور مصطفى غلوش. I'm the Chief Quality Officer in Saudi German Health. Actually, it is my pleasure, Dr. Amahi, for the invitation, and I'm very pleased and honored to be among Ain Shamsi University professors, and they are my professors, and it's my pleasure, of course. Of course, and when I am being introduced by Dr. Assaf, this is also another layer of pleasure and honor, Doctor. Dr. Amahi and Dr. Assaf, without any kind of introduction, they are changing the healthcare quality across like the world, like Dr. Assaf, across Egypt, like Dr. Amahi. Thank you again for invitation. We will go through the process of implementation of value-based healthcare in Saudi German Health. Just an example. Of course, the presentation has a lot of achievements. And we will be happy to see your feedback as well during my presentation or after this. So what is Saudi German? حقيقة القول هي السلايد just to show you that how this kind of organization is a big organization. We are striving to value-based healthcare just to ensure that this kind of like an empire of facilities will run in the standardized way getting the most agile outcomes to our patients and ensuring that while we are implementing the value-based healthcare, we will get to our slogan, which is caring like family. It's a very simple, actually formula, and Dr. Assaf started with it. So we need to see the quality from the side of the patient. يعني احنا بنشوف من ناحية البيشنت أكتر من ما نشوف من ناحيتنا. وده الترانسفورميشن actually to value-based healthcare. واحد من الحاجات المهمة اللي انتوا سألتوا عليها كمان إن it's not a movement of one provider or healthcare facility, it's a movement of the whole ecosystem. Ecosystem means regulators, means government, means payers, providers, and the patient as well. So it's like an ecosystem, and in Saudi Arabia we have like a very ambitious change, transformation in the healthcare, and one of these kind of KSA vision is the healthcare of the healthy population. Healthy population means we need to ensure that we look to the health outcomes for our patients in Saudi Arabia. So how we have done it, and it's very crucial for everybody. Whenever you see, يعني تبتدي تبص على الهيلث كير أو على الفاليو بيزد هيلث كير أو الكواليتي، لازم تبص على الستيك هولدرز. And this slide is very simple, but it like articulate the whole story behind value-based healthcare. So the patient should be in the center of everything that we do, and this is why we are transforming to value-based healthcare. The other thing that everybody needs to work together. So providers, international entities, payers, regulators, and I'm giving this slide just to, and I'll go through one by one. Why? Because you need to work not only with yourself, you need to work for the sake of the patient with everybody around you. And a lot of changes should happen in the mindset of the quality team and also in the leadership. So let's talk about one thing that is a collaboration. So whenever we talk about accreditation, we need to move it towards collaboration, ensuring that whatever accreditation we do is for the sake of the patient. And this is why we changed this in Saudi German Health. We seek accreditation, of course, because it will affect the payment, the marketing, but at the same time, we use our accreditors like international and national in different ways. And one example is the ACHSI. So as you كلكم عارفين in accreditations we have international and most of the organization are using it for marketing. احنا استخدمنا الأستراليان. We have benchmarking with them to ensure that whatever we do as a standard will be reflected into the KPIs, outcome KPIs for our patients. So we have like as you can see, one of the indicators that we use with them is ER revisit within 48 hours. And we have like benchmark ourselves towards the ultimate excellence in healthcare. But in the same time, we have this kind of collaboration with our regulators. So one of the things that whenever we talk about value-based healthcare, you need to transform this kind of science, and we have a lot of examples here, into something called framework. So what we do, what we shall do, إيه اللي هنعمله عشان نطبق value-based healthcare. So in Saudi German Health, we changed the whole thing about the quality. We have our own quality framework. We changed the performance improvement and performance measurement into value-based healthcare. So the value-based, any kind of measurement, any kind of performance improvement will result in something for the value of the patient. So we have 3 pillars. We have quality review, we have patient safety and risk management, and we have value-based healthcare as one of the pillars of our QBS framework. And of course, to do this, we have 4 pillars, again, our 4 areas that we need to focus on. Provision of business, how we can do this kind of value-based healthcare practices. Capacity building, we need to build the capacity of the healthcare workers and also the quality team. Research and marketing, we need to ensure that whatever we apply is based on evidence-based. Accordingly, we need to have measurement and control in place. To do this, we have like this cycle, and in value-based healthcare, we have a lot of processes that we are working to standardize to ensure that the value will get to our patient. And one of them is having proper analytics in place, and the analytics is directed towards the outcomes rather than the process. I'll give you a very small scenario happening in most of the accreditation. So if anybody have like JCI or any kind of accreditation. And one of the standards is talking about measurement. So if I have in my hospital, the mortality rate is 50%. And I measure this and I give it to Joint Commission or any accreditation. I'm not saying any name of accreditation, but any accreditor. The score will be fully met. Why? Because we are measuring it. So we need to transform this towards, even if we are measuring, we shouldn't be appreciated unless we have the outcomes reach the patient. So somebody needs to do something related to the outcome. So this is transformation in the mindset, even from regulatory perspective or accredited perspective, should be there. So whatever we do in value-based healthcare as one of our functions, we focus on the outcome. So we need to measure the process, we need to measure the structure, but at the end, we need to see if this kind of process and structure yields to something to our patients or not. So I'll give you a lot of examples during my presentation. So to do this kind of value-based healthcare, we have 4 pillars. We need to focus on productivity. We need to ensure efficiency. We need to have cost in our mind, quality and cost in our mind, and we have quality pathway. Whenever we talk about quality, we need to address the 4 areas. It's not only one area. The 4 areas is the CROMS, clinician-reported outcome measures, which is related to clinical healthcare outcomes related to clinicians. PROMS, which is patient-reported outcome measures, and this is representing the quality of life. And of course, the example given by Dr. Assaf, Prof. Assaf, is very clear. The staff, the hospital, from their indicators, they have 100% success rate in the case. But at the end, if I measure the quality of life of the patient, we have a lot of failures here. It's not related to the provider, it's related to the ecosystem. And this is why whenever we measure outcomes, our quality, we need to ensure that PROMs are in place. PREMS is a patient-reported experience. The experience is measuring the exposure to the environment, the process, the waiting time, and this is very crucial as well. So we need to measure the PROMs, the PREMs, and CBGs to ensure the process of the guidelines are done properly. So this is the main framework. And of course, without commitment from the leadership, and this is why I give you the values of Saudi German Health. So caring like family, we need to implement it in quality and other functions, of course. So having this kind of preparation for the leadership involvement, and I can tell you from day one, when we start to speak about PROMs, it was like Chinese for everybody. So you need to ensure that you get the board on board. And there is a very nice paper from IHI called How to Get Your Board on Board. Every quality staff or quality professional need to exercise this white paper in his day-to-day. Because it's not only, I know the right, and I'll tell you. You need to ensure that you will engage people with you to get the outcome for your patient. So this is what we have done. And of course, to ensure that we are measuring, we need to have like a full cycle of validation and ensuring that our outcomes or any kind of indicators are representing the facts, not only just measuring. And there is a very hectic process to ensure this, and there is data analysis in place. And you need to measure this kind of areas, specialty-based performance. Specialty means ER, obstetric and gynae, surgery, this specialty is doing well or not. Condition-based, which is related to specific diseases. Population health, and when I talk about population health, in a private healthcare provider, it's very challenging. Why? Because the patient still has the liberty to go to any provider. So having population health focus is a new paradigm shift, but I'll tell you how we are tackling it even with the payment with the payers. Because we want to be play an effective role with our payers. So whatever we do, well, I'll explain how we can ensure that it is aligned with the payers as well. And of course, we can have a lot of impact from this kind of modeling. So just a quick oversight about the number of indicators. All of this are like more than 218. And I'll tell you for a fact, working as an assessor for healthcare facilities, there is some hospital has more than 1,000 of indicators. And when you ask about outcomes, it will be very, very hectic for them to get for you. So you need to ensure that these are there. One of the things that Prof. Assaf talk about is the live dashboards. Something you need to not lag indicators. You need to have something to tell you somebody is waiting. Somebody is now. We need to take care of this patient now, because any kind of lag indicators will not have a value there. Any kind of audit is redundancy. So you need to work immediately, and this is how we need to ensure that the controls are inherited in our day-to-day practice. So, of course, patient-reported outcome measure, and we have a lot. We are very proud that we are the first in Saudi Arabia to measure this kind of, to have this number of filled questionnaires. So we address all kind of diseases, especially the asthma and diabetes. And of course, we use a lot of tools. The most important thing about PROMs to use the validated tools that suits your culture. And there is a lot of PROMs, validated tools will not suit our cultures. So you need to ensure that. And we are working with ISHUM. We are partnering with ISHUM to ensure that we are translating it in the way that everybody will understand it culturally. So quickly, it's very important, as I said, we need to ensure that all of these dashboards are there, and this is 2025 outcomes. And one of the important slide that I need to show is whenever you measure, as I said, you need to address the 4 domains. So if I'm talking about diabetes, you need to ensure productivity, that you see patients, outpatient, inpatients, whatever. You need to ensure efficiency. You need to ensure finance and quality. Here there is a dilemma. Why? Because I'm a private hospital. So I need more and more patients. But if you measure the population health or the effect, the burden of disease, of diabetes, you need to lower the admission and the ER visits for your patients. So as a private, I need more patients, but I need to apply the population and value-based healthcare. And this is why having your data, having your case, and going to the payer saying that these your patients, they are the burden of, or the cost of your patients, and I'll take the money, of course, but the burden is X, so let's change the contract from fee-for-service or whatever to bundle payment, incentive payment, a lot of, why? Because this case will help him to reduce his cost and reduce my cost as well, and reduce the cost of the burden of the disease in the health ecosystem. Did you get my point? So we are using this. Actually, we have with Bupa, we have with Taawuniya, we have a lot of case studies. We need to ensure that whatever we have, this is your data, this is your patient, this is the burden. Let's do this kind of contractual agreement with you. And we are working as well with the regulators. And of course, as I said, it's not a dilemma now. We started now some of these types of contracts, incentive-based and also bundle payment. So this is like how we can change this. One of the things that I'm very proud of, even I'm private, and again, a lot of challenges, even to access some of the patient data. But I can tell you that we increased the hemoglobin A1C compliance, and this is not a common slide from quality perspective, actually. So we increased the hemoglobin A1C compliance for our patient, 11%, reduction in chronic complications. And thankfully for ISHUM, and I'll tell you why I'm saying ISHUM, because they are responsible for outcome measures. And this is why we are the first, I'll go through this slide quickly, and then I'll talk about ISHUM. So low back pain, this is another area that whenever you need to have the value-based healthcare, you need to ensure that you have something called value chain in the disease management. So value chain can start from the patient admission till the end, or it can be crossing all the healthcare sector. So ambulatory, hospitals and also rehabilitation. But because we are in a hospital, we focus on the area that we have. And this value chain, when we calculated the inherent cost, enabled us to do the first bundle payment contract with Ta'awunin. And this is why they will love to pay for something that matter for the patient. Did you get my point? Okay. So this is the beauty of measuring the PROMs, the patient reported outcome measures. You can imagine that the quality of life increased from 6.8 to 9.1 in the patients, for our patients. It can be because we treated the disease, it can be treated the symptoms, or even addressing the whole journey of the patient from life perspective. And of course, we are the first accredited in Saudi Arabia from ISHOM, and this accreditation, again, it's a marketing. I need to publish this. But in the same time, we have this kind of partnership to ensure that whatever evidence-based tools or validated tools, we can get it. And of course, there is an open communication with them. I not go through all of this, but one of the things that Prof. Assaf mentioned, that you need to start using predictive. And why I'm referring to this? Because we start to use a tool called predictive analysis for chronic diseases for diabetic patients. Why? Because these kind of patients that we predict that they may have chronic diseases, we can assign some coordinator, patient educator, case managers for them. So in replacement to waste the resources for every patient, you can just focus on them. So this is the last slide that I have, and I would love to thank you and thank, of course, Prof. Mahi, and thank you.
Shukran, Dr. Hayak Allah. This is wonderful. I have a question for you. Okay, so you have, these are really excellent results, the way I see it. Do you think that you are doing much better than in one hospital more than in another hospital? So if you compare between hospitals, is there a difference, and why is that difference?
Yeah. So, of course, when we have this kind of benchmarking, either we have in our internal benchmarking or external benchmark. Some of the indicators we have are external, and external benchmark like NDNQI for nursing, for example, whatever. And of course, we have still our internal comparison. Of course, the difference is still we are building this kind of standardization, but still, as you said, Doctor, we need to focus on priorities and ensure that the model will work in one place, and then we can go to the other place. So sharing the best practices is challenging as well. And as you can see in the first slide, we have almost 13 hospitals in place. So shifting this kind of best practice from hospital to other hospital, it's a challenging thing, but we are trying to be like a learning organization. Thank you.
Yes. Any other questions? Any other questions from the audience? We have about, yes, please, in the back.
السلام عليكم. مجدي حسن، زمالة عربية طب أزهر تخدير ورعاية. الكويشنز او يعني الكومنتس بالنسبه للتوك بتاع الدكتور عساف، الشورتج اوف فيزيشنز ان ريليشن تو ذا جريت نمبر اوف ذا بيشنتس، اعتقد انه كان بي سولفد باي تيم ورك ابروش، ان انا ما اتحملش ريسبونسبيلتي سولو، يعني فير ديستريبيوشن للجوب از ا تيم ورك ابروش which is significant in our society. The second point, second point ان احنا concise as a professional في السبيشاليتي بتاعتنا. لو احنا فكرنا step behind و step after، البيت فولز اللي حضرتك قلت عليها ريننج روف او he cannot make a garden like he's not a gardener like before. لو انا conscious one step behind عن السبيشاليتي بتاعتي one step after عن السبيشاليتي بتاعتي, also this problem will be solved. Yeah. I know it's extra duty, but it's fruitful يعني.
Yeah.
It deserves a cost يعني سواء كانت على الطبيب أو على السيستم. في نقطة ثالثة بس بحاول أسترجعها لأن
And Doctor, do you see that there is any value in incentives? In incentives.
What do I know?
Motivations.
Motivations.
Yes. So how can you move a hospital from one place to another to better place, or a physician from one activity to the next activity in a better way? Do you see any place for incentives?
It comes by knowledge, then practice, not the reverse.
Okay.
You have a good array of knowledge, then guided and supervised in practice.
حلو.
So it will be safe and productive.
I understand.
And always regressive, as the progressive attitude, less problems يعني will be evolved.
Very good.
Thanks a lot.
Thank you very much.
Salam.
Appreciate it. Doctor, do you want to add? Okay. I think we don't have too much time, so let's move. And then if we have more questions later, we can do that. So I think the next, شكرا دكتور. حياك الله. So we have the next speaker is Dr. Azhar Ali, and Dr. Azhar Ali will be joining us from where are you in Egypt or outside Egypt? Oh, he's in Saudi Arabia. Okay, very good. Okay, so he is going to present to us improving value at the point of care, practical approaches to improving quality and outcomes, whilst reducing cost and waste. And Dr. Azhar Ali is the Chief Medical Officer in Elixir Health Limited in Riyadh, Saudi Arabia. So probably we need to know more about Elixir Health, if you don't mind, and then tell us a little bit about your background. I would like to know that, and then we're looking forward to your presentation. Thank you very much, Dr. Azhar. Go ahead.
Assalamu alaikum warahmatullah. Good afternoon. I'm just let me just share my screen.
Okay.
With the presentation. Do you see my screen now? How about now?
Yes, we got it. Thank you.
Excellent. Great. Thank you very much. Good afternoon, everybody. Assalamu alaikum warahmatullah. It's a pleasure to join. Apologies, I couldn't be there in person, but greetings from Riyadh. My name is Dr. Azhar Ali. Professor Asaf, thanks for the brief introduction, and I'm happy to tell more about myself. I'm a family medicine physician from the UK, currently working in Saudi Arabia. Actually, I'm working in the National Health Insurance in Saudi Arabia, which is the new public health insurance entity, which is focused on value-based healthcare, population health management, using payments, incentives across the public health sector. My presentation today is going to be focused on some work that I started in my previous role, where I was vice president at the Institute for Healthcare Improvement, IHI. So I used to lead IHI's work in the Middle East and Asia Pacific, and so had the pleasure of working with colleagues across the region for several years. So this is what I'm going to be talking about, some work that we started during that time and moved on. And of course, work continues. It's a pleasure to be here. I worked with many colleagues from Egypt, and I always hear about Ain Shams University as being one of the prestigious and top universities from both Egypt and indeed the region. So thank you for the organizers, Professor Mahi and others, for inviting me here. As I mentioned, the topic is really about value, but not really the value-based healthcare we talk about when we talk about PROMs and PREMs and things, but really an approach that was developed by IHI around 7 years ago now, focused on improving value at the point of care. So really empowering the frontline teams to deliver value using quality improvement methods to both improve the quality of care, but also consider cost and waste and reduce cost and waste. And this work actually started initially through IHI's innovation function, which the innovation function at IHI generated things like the AAA, generated things like bundles for CLABSI and various other bundles. So many of the the leading things that IHI came out of that innovation function, and improvement methodology was one of those. It started off being piloted in Scotland, in the UK, then it quickly was implemented in Qatar, in the public health system there. It was also deployed in New York, Northwell Health, I think Canada, and more recently in NHS England as well. It's been deployed as well. And really why, I suppose the first question is, what's the problem? And if you think about, a particular focus from a frontline perspective, what happens in the time that you spend? If you spend an hour of your time, there's a lot of time spent with waste, waiting, and not always adding value, looking for information, interruptions, doing rework of things, delays. So really, efficiency is not about doing things faster. It's about doing things in a reliable way, in a smooth way, and removing the frustration both for the front line, but also for the individual patients as well. So this is really was one of the reasons for this work to be developed. And as you know, health systems have lots of data, but how do we translate that data into actionable information, useful information that we can use to improve the care that we're providing? How do leaders get the useful insight into that data, and how do frontline teams actually take that data and look at how can we improve quality and reduce cost? And I just want to highlight the value equation, which is a simplified approach, but quality over cost. So quality includes things like outcomes, it includes the patient experience and other measures that you might want to add, whether it's PROMs, PREMs, and other measures that you might want to add. And cost, of course, there can be different ways of looking at cost, different ways of calculating cost, whether that's looking at direct costs, indirect costs, and different methodologies that you deploy. This approach that was developed used something called lean accounting. So I think in the first iteration, we used time-driven activity-based costing, which is, if anyone knows about that, is a very cumbersome, burdensome approach. But really, the focus was on having just enough financial and cost data that's needed, and to have data that is that you can influence. So the frontline teams can actually use that data in a way that they can make a difference. And there's no point in having data, for example, that you can't make a difference on, for example, staffing costs or salary costs, where you're not, as a frontline team, you're not able to change those. But maybe some staffing costs or consumable costs, supply costs, these are things that you can make a difference. So it's really about having the right data, the just-in-time data as well in place. So this came through from lean accounting, which is an established methodology in other industries. So it's an established financial methodology already in place. But this is really just about how do we apply this in a healthcare setting. So the IHI value management methodology, as I mentioned, it's been developed, it's been demonstrated in multiple countries now, multiple different settings, and actually even within hospitals, different units, whether acute care units, long-term care units, critical care, operating theaters, even having seen it deployed in non-patient care units like hospitality and food and catering components as well. So it's really about how do we drive better outcomes, better experience at the lowest possible cost. And I'll be able to show you some of the data and results that we've managed to get through this work. So what is this method? Really, why, the core principles of this is around understanding variation. What's the variation in processes? Is the process standardized? Is it predictable? Is it reliable? What harm is happening? So it aligns with safety. Is there harm that's happening within the system? And of course, is there waste that's happening in the system? So aiming to both eliminate harm, eliminate waste, and reduce variation, which really is the fundamental principles around quality improvement. So it's not moving away necessarily from the quality improvement methods, but essentially it's about using some of the, putting some focus on efficiency, sustainability, and waste as well. And this is just really a conceptual. This was part of the output from the innovation work, is really asking yourself: do you have a standard process. So when when a frontline team starts looking at a particular process, do you have a standardized approach? Is there a standard model? And the one way you can do this is by asking 5 different people, what's our process to do this? If you take something like dispensing medication, what's our process to do this? Do you have a standardized process? And if you have 5 different answers, then you don't. And then mapping that process out. So using standard process mapping techniques helps you understand the process, helps you understand the variation. So if you're looking at time or different steps in the process, you can understand the variation in that process. And ultimately then being able to redesign that process using quality improvement concepts, using concepts like simplifying, coordinating, substituting, and that allows you to then improve and optimize for efficiency. If you're tracking costs with that, once you start to improve those processes, you can understand the impact on cost and reducing waste. And then you can redeploy that optimized capacity. Either you have you use that redeploy it in a different way, or you're reducing costs. So there's elements of cost avoidance versus cost saving as well. And all of this needs to be done. So this is not about cost cutting, and consistently need to check the quality of care. Are we delivering high quality care? Are we looking at patient experience? Are we looking at staff engagement? Is there an impact on job satisfaction? And all of this is really needs to be continuously part of this process of improving value. So what are the components of this value management methodology? And I'll go through these in detail, but there are 3 main components. So the one is around visual management. So using visual management tools to really support the way the team works. Secondly, it's around daily and weekly communication. So typically using huddles. And then the third component is using the improvement capability, using the typical quality improvement, whether you use PDSA, Focus PDCA, whatever improvement skills and capability, Lean, Six Sigma, you can deploy any, and it's agnostic to that approach. So these are the key components of this, and underpinning that is the data as well. So it's really important to have the data available in a timely manner. So this is not about having quarterly data, but actually through the visual management, we look at weekly data. And of course, like any improvement work, we need to think about the problems. What are the problems we're trying to solve? What data is needed to understand the root causes of those problems? Having leadership to empower the frontline teams to improve. And then ultimately what we all want to see is better outcomes, reduce costs. We want to see results. We want to see impact. All of that needs active leadership support. So one of the key components of this work is making sure that there's a proactive leadership engagement and not passively, but actually proactively supporting this work. And ultimately, what we're looking to see with and what we've experienced is how do we deliver sustainable improvement? So oftentimes we'll see improvement is delivered, but when you look away and come back after 6 months, it's not sustained. And so this approach gives you a method that you can move away from this is a project to this is the way we do things. So it changes the culture within the team, it gives ownership to the team, it changes the levels of engagement and empowerment of the frontline teams as well. So it empowers the teams to solve their own problems, identify the problems, solve the problems when you put the data in the hands of those teams. So just to go through the different tools and components. So first of all, it's important any work at the front line is linked to the strategic level. So if you're in a hospital, as a leader, you want to make sure that the work that's happening at the front line is going to help the organization move forward and move the needle on key results that are important. So, and there are tools within this. We use a linkage chart to connect the strategic objectives to the frontline objectives. And this allows frontline teams to actually better understand the strategic priorities and goals, but it also allows them to select and look at things that are important for them as a frontline team. but it still aligns with those leadership objectives as well. Secondly, we have something called the box score, and the box score is really where the data is and using close to real-time data. So as I mentioned, not moving to typically organizations will have quarterly data, and this is like, you know, when you're driving forward and looking in a rear view mirror, this, quarterly data is looking back. And what you really need is real-time data to react and act on that immediately. And that is data, whether it's about cost or quality. And so this is the box score. The box score is split up into 3 different components. I'll go into that in a bit more detail. Then the improvement techniques, as I mentioned, using PDSA, using the typical tools, process mapping, root cause analysis, Pareto, whatever tools that are needed, and that toolbox is always going to be important. And lastly is the visual management, using the visual management board and having the weekly huddles. And these are there to create transparency and accountability across the teams. You have a multidisciplinary team that working together on this. So these are the key components. The box score, as I mentioned, is split up into 3 components. You have performance metrics, so these could be any quality metrics, any safety metrics, any metrics that are important both to the team but also to the organization. Then the capacity metrics around typically looking at staff capacity. For example, one of the common ones is looking at nursing time. When is nursing time being used for direct patient care, indirect patient care, or other tasks that are not adding value to the patient. And lastly is the financial metrics, looking at costs, whether that's supply costs, medication costs, other types of costs, other types of costs, and whatever costs are available, but also can be influenced as well. So performance, capacity, and finance. So this is what really makes up the box score. It's not something that's rocket science. It's a simple table, but it's breaking down the data into a weekly basis.
Dr. Azhar, if you could wrap it up within 2 minutes, we were just a little bit late. Thank you very much.
Sure. So the improvement techniques, I won't go through this. Many of you will be familiar with this. And then the visual management. This is you can use this very quick, easily. You have your box score. You have the improvement techniques, and this is really about creating transparency amongst the teams as well. And the huddles brings that all together, where you have a weekly huddle, 15 minutes standing up. It's multidisciplinary, so this is not a long meeting, and that allows people to question, discuss. You'll have leaders there, you will have pharmacy, doctors, nurses, all of the team is there in the huddles. And we know from other experience that huddles really can have a significant impact on how teams work. Typically, when we've done this work, it's been a pilot unit and then scaling up to multiple teams. More recently, we tried this work in Saudi Arabia, where we used the IHI BTS methodology, the Breakthrough Series methodology, and started with 22 teams and showed significant improvement. And so this is just some of the impact from a financial. We've seen the most recent work, $3 million in savings from just 6 teams, some significant savings. So we're translating improvements in safety and quality of care to actual impact in savings, whether that's from pressure ulcers, whether that's from things like rework or blood sampling, and reduction in patient harm. What we've also seen is that there's been an improvement in culture. So there's been teams measuring safety culture. There's been teams measuring satisfaction from the staff, and we've seen that in the results that we've monitored as well. I'm just going to a couple of slides on examples. So here you can see from a cardiothoracic ICU unit showed a 70% reduction in X-ray costs, which is absolutely significant. So really making sure that you're using this most effectively. This is a control chart. You can see the changes that they made and monitored over time as well. Similarly, this is a high dependency unit, discharging patients in a timely manner, which of course, as you know, can have an impact on the flow of patients, bed utilization as well. Reduction in consumables. This is a cardiac ICU, and again, more than 50% reduction in cost of consumables over a 3-year period. And again, the teams are using the control charts as well. So these are just some examples. This is from Scotland, where they had a 25% reduction in what's called bank nursing, which is ad hoc nursing costs. So again, is something that the teams could influence, and they've managed to reduce cost of average cost per patient by a significant period of time as well. So these are, I won't go through all of these, but there's lots of different data that we've got. There are a number of publications that you can find online, and this is just some examples of those that you'll see that share the actual specific projects and results. The methodology was published in the Harvard Business Review. There's a book that's been published by some colleagues from IHI and other faculty that was just published in fact January. This is December, and you can find out more about this book as well. And this describes the methodology in detail and how you can apply this yourself and take it. And really, this can be applied by individual teams. It can be applied by a hospital, or it can be applied by a large health system as well. So that's all from me. Thank you very much for listening. Happy to take any questions.
Yes.
Thank you.
Thank you very much, Dr. Ali. Dr. Azhar, these are very impressive results, really true. I think we have just a very few minutes for a question from the audience, if anybody is interested in a question. Yes, you have a question? Yes, please. You have one question.
يعني هي مش question قوي، ولكن هنقول ان احنا دلوقتي برضه الدكتور أزهر والدكتور مصطفى، احنا دلوقتي محتاجين ان احنا نوصل الفكره اللي هو المعتاده انه الاعتماد مش هو الهدف، الاعتماد هو تول. فاحنا محتاجين الامبروفمنت بروجكت اللي كان بيتكلم عليه دكتور أزهر، احنا نبتدي في ان احنا الفريق يبقى بارتيسيبيتنج. يعني انا ممكن اعمل امبروفمنت بروجكت ان الفريق بتاعي يبقى بارتيسيبيتنج. بالنسبه للسعودي الالماني، لما عملنا مره لقاء مع دكتور ياسر بتاع الاشعه، رئيس قسم الاشعه، كان بالنسبه لي حاجه غريبه ان رئيس قسم الاشعه بيتكلم معايا كانه كواليتي. هو عارف كل حاجه في القسم، واحيانا بيعمل يعني سياسات وحاجات اكتر من المعايير عشان هو ايده فيها وعارف بيعمل ايه. فاحنا محتاجين الاول انه كان عندنا يعني دكتور كان بيقول تول للوصول، يعني المعايير مش الجول بتاعتي، لكن هي تول مجرد وسيله ان انا اوصل. فاحنا محتاجين نتعب شويه في ان احنا نهيئ الفريق بتاعي. انا باجي له فجاه اقول له انت عندك 3 شهور لازم تخش اعتماد، لا حضرتك انا براحتي خالص وابني ده، لان هو ده اللي هيطبق. هو مجرد ما هديله سياسه هيطبقها، لو اديت له تدريب هينفذه. لو سبيك اب دي المفروض يبقى للايه، للفريق زي يعني المريض يعني. فشكرا لتعب حضرتك.
شكرا. Thank you, Doctor. This was more like a comment, Dr. Azhar, than a question. So probably the gist of it is that they love some of your projects, and they would love to implement it in their hospitals. So they may contact you for guidance into mimicking some of the activities in their hospitals. And again, thank you so much for your contribution.
Yeah, happy to absolutely happy to connect with anyone and give advice and input into whatever projects. And of course, those projects are projects that were selected by those teams, aligned with their own strategies, and they may be different projects. So I think the key thing here is there's a methodology that moves away from this is a project to this is how we do things. This is the way we manage it's a management system, I would say, rather than just a project. But yes, then you apply that management system to the problems that you have and different projects that are different areas, I should say, that are important to you. But yeah, happy to connect with anyone needed. Either I put my LinkedIn details up there, but happy to share.
Thank you so much. Really appreciate that. Appreciate it. Appreciate your contribution. I think we move to the next presentations, please.
Yes. طيب شكرا جزيلا دكتور أزهر ونورتنا.